According to Brunstrom, ankle and foot is a complex system made up of 26 bones. These bones include the distal segments of the tibia and fibula, talus, calcaneus, 3 cuneiforms, navicular, cuboid, 5 metatarsals, and 14 phalanges. Ankle and foot is supported and moved by 34 joints and over 100 muscles, tendons, and ligaments, making it flexible and conforming to irregularities of different terrains that is important in daily functions. The motion of the ankle and foot is important in propulsion. During dorsiflexion, the angle between the leg and the dorsum decreases and is primarily moved by muscles tibialis anterior, which also inverts the ankle. Also, other muscles, namely extensor hallucis longus, extensor digitorum longus, and peroneus tertius muscle. Plantar flexion is the movement plantarward caused primarily by gastrocnemius and soleus muscle. Other muscle passing posteriorly to the axis of motion of plantar flexion contributes to the motion, such as tibialis posterior, that helps control and reverse pronation during mid-stensive gait. Flexor hallucis longus and flexor digitorum longus muscles flex the toes and help support the medial longitudinal arc. Inversion is the inward turning of the foot, and eversion is the outward turning from the frontal plane. Motions happening in the transverse plane includes abduction, which is the movement away from the midline, and adduction, which is the movement towards the midline. The motion of the foot may happen in combination of motions within a triplanar plane. These are pronation and supination. Pronation is the combination of dorsiflexion, eversion, and abduction. During weight bearing, pronation of the subtalar and transverse tarsal joint causes the arc of the foot to lower. The opposite of pronation is supination. It is a combination of plantar flexion, inversion, and adduction. In the weight-bearing foot, supination of the subtalar and transverse tarsal joints with a pronation twist of the forefoot increases the arc of the foot. The ankle or talocrural joint is a synovial hinge joint formed by the mortise and trochlea of the talus. It is enclosed by a relatively thin and weak capsule. It, along with subtalar joint, is supported medially by the medial collateral or deltoid ligament and laterally by the lateral collateral ligament. The surface of the talus is wider anteriorly and also cone-shaped, with the apex pointed medially. When the foot dorsiflexes, motion of the foot, the articulating surface of talus slides in the opposite direction. The subtalar joint attenuates the rotatory forces between the leg and foot to prevent excessive inward or outward turning of the foot. In an open chain motion, the convex posterior portion of the calcaneus slides opposite to the motion. The concave anterior and middle facets on the calcaneus slide in the same direction. Therefore, with the component motion of eversion, as the calcaneus swings laterally, the posterior articulating surface slides medially, and with inversion, the posterior articulating surface slides laterally. The talonavicular joint is supported by the spring, the deltoid, the bifurcate, and the dorsal talonavicular ligaments. This joint works together with subtalar in pronation and supination. During pronation, the head of the talus drops plantarward and medially, resulting in a pliable foot and decreased medial longitudinal arc. During supination, the opposite occurs, resulting in a structurally stable foot and an increased medial longitudinal arc. The calcaneus inverts and the talus dorsiflexes and everts, resulting in a navicular plantar flexing, inverting, and adducting. With physiological motions of the foot, the navicular slides in the same direction as the motion of the forefoot. In the open chain motion of pronation, the navicular slides dorsally and laterally, and with supination, the navicular slides volarly and medially. The important lateral ligamentous structures include the anterior talofibular ligament, posterior talofibular ligament, and calcaneofibular ligament. The anterior talofibular ligament runs from the anterior edge of the lateral malleolus to the talar neck, attaching just anterior to the lateral malleolar facet. It is the most important lateral stabilizer of the ankle, being the primary restraint to supination and anterior translation. It also limits plantar flexion and internal rotation. The posterior talofibular ligament courses from the posterior talus to the back of the lateral malleolus. It is located deep and is the strongest of the lateral ligament complex. The calcaneofibular ligament lies deep to the peroneal tendon sheath, originating from the tip of the fibula to the lateral tubercle of the calcaneus. The medial ligament of talocrural joint or deltoid ligament is a strong, flat, triangular band attached above to the apex and anterior and posterior borders of the medial malleolus. The deltoid ligament is composed of the anterior tibio-talar ligament, tibiocalcaneal ligament, posterior tibio-talar ligament, and tibio-navicular ligament. It consists of two sets of fibers, superficial and deep. Of the superficial fibers, tibio-navicular pass forward to be inserted into the tuberosity of the navicular bone, and immediately behind this they blend with the medial margin of the plantar calcaneonavicular ligament. Tibiocalcaneal descend almost perpendicularly to be inserted into the whole length of the sustentaculum tali of the calcaneus. Posterior tibio-talar pass backward and laterally to be attached to the inner side of the talus, and to the prominent tubercle on its posterior surface, medial to the groove corpus, the tendon of flexor hallucis longus. The deep fibers, or anterior tibio-talar, are attached to the anterior colliculus of the medial malleolus and below to the anterior medial talus. During weight bearing, subtalar motion and tibial rotation are interdependent. Supination of the subtalar joint results in or is caused by lateral rotation of the tibia, and conversely pronation of the subtalar joint by medial rotation of the tibia.
An ankle sprain refers to the tearing or stretching of the ligaments of the ankle. The most common ankle sprain occurs at the lateral aspect of the ankle. This is an extremely common injury which affects many people during a wide variety of activities. It can happen in the setting of an ankle fracture. There are three types of ankle sprains. The first one, lateral ankle sprain, usually is from a inversion plus plantar flexion injury leading to the stretching or tearing of the lateral ligaments of the ankle. The second one, a medial ankle sprain, usually from an eversion plus dorsiflexion injury of ligaments in the medial side of the ankle. Because the deltoid ligament is very strong, this injury is rarer and can take up to twice as long to heal than lateral ankle sprains. This is often associated with the fractures of the fibula or the medial malleolus, talar dome, and articular surfaces. And the last one, the syndesmotic ankle sprain, an injury to the front or back lower ligaments of the ankle. This often occurs from hyperdorsiflexion plus eversion. The anatomical classification of ankle sprains include three grades. Grade 1, ATFL is stretched. Grade 2, ATFL is torn plus a CFL stretch. Grade 3, ATFL and CFL are both torn plus a stretch in the PTFL. The American Medical Association uses a generalized scale based on the degree of ligamentous injury. Grade 1, ligament is stretched. Grade 2, there is a partial tear in the ligament. And grade 3, the ligament is completely torn. When chronic ankle instability is present, it can also be divided into functional and mechanical instability. Mechanical instability involves pathologic hypermobility of the tibio-talar joint. This is typically delineated by a talar tilt discrepancy greater than 10 degrees or an anterior difference of 10 millimeters compared to the contralateral ankle. The functional instability is ascribed to sensory motor and neuromuscular deficits that accompany ligamentous injury, but mechanical instability is not necessarily present. Alternatively, chronic ankle instability has been described by Carrison as the subjective complaint of a patient, apprehension, or recurrent ligament sprain. This classification is supported by an increased reaction time of the peroneus longus muscle in unstable ankles. The hallmarks of chronic ankle instability include repeated ankle sprains that have led to an altered patient activity level. Important factors include injuries sustained, frequency of events, localization of pain, and prior treatment modalities. The degree of disability appreciated by the patient is one of the most important factors and can be significant in both high and low demand individuals.
So let's start off with the subjective. Demographics of the patients are as follows. Patient has the initials of 80 and is a right-handed male who is 21 years old, non-hypertensive, non-diabetic, and non-asthmatic. Patient's chief complaint is a feeling of instability on the right ankle whenever the patient ambulates. It is consistent with the presentation of chronic ankle sprain complaints discussed earlier, where it states that chronic ankle sprain concentrates in functional instability or persistence of residual complaints such as the ankle giving way or a feeling of recurrent spraining or even both. History of present illness. Condition started 4 months ago when patient fell on an inwardly placed foot after doing a layup during a basketball game. Patient felt pain on the lateral aspect of the right ankle, graded 9/10 using the subjective pain scale. Patient elevated his foot and applied ice for approximately 20 minutes with immobilization. As mentioned a while ago, the most common type of ankle sprain is caused by landing on the outside edge of the foot. This causes the ankle to roll in and sprain the ligament on the lateral part of the ankle. Patient went to a doctor for consult and was advised to continue elevation and ice application. Patient was also advised to take ibuprofen for pain relief as necessary. Ancillary procedures done were X-ray, which revealed absence of fracture, and an MRI, which revealed a grade 2 ankle sprain on the right ankle. As mentioned, grade 2 ankle sprain consists of partial tearing of the ligament with laxity of the joint. Patient was advised to undergo PT management but only completed 2 out of the 6 weeks with 3 sessions per week. Patient ceased with PT treatment due to lack of time and loss of pain on the right ankle. Management done includes cold packs, bandaging, and exercises which the patient cannot fully recall. Past medical history. The first incident of ankle sprain that the patient experienced happened a year ago when he landed in an inverted foot from a layup during a basketball game. Patient underwent PT management after, which includes cold packs, bandaging, taping, and therapeutic exercises. Patient's lifestyle. Patient is a small forward in a basketball team in college who trains from 6 a.m. to 10 a.m. He is also a student and attends class from 12 noon to 4 p.m. Patient is a non-smoker and non-alcoholic beverage drinker. For environmental factors, the patient lives on the 9th floor of a condominium with elevators, with approximately 10 steps from the elevator to the room, about 15 steps from door to bedroom, and about 10 steps from bedroom to bathroom. His classroom is on the 3rd floor, with stairs about 20 steps per flight, and he trains on a hardwood flooring. So for the shoes, according to KNGF guidelines for physical therapy in patients with chronic ankle pain, evidence on the optimal use of footwear is contradictory. Some authors recommend high-top shoes, whereas others recommend a low-top shoes. Barrett et al. Found no strong relationship between the shoe type and type of ankle injury. Verhagen et al. Concluded that the use of new shoes probably has a greater preventive effect than shoe height. Inconsistency found in the subjective report is that there are current complaints of instability during walking but not during basketball trainings, which actually gives more stress to the patient's foot.
For objective part, vital signs are observed and revealed to be normal. For ocular inspection, patient is ambulatory without assistive device, oriented to person, place, and time. Patient is mesomorph with gait deviations and postural asymmetries. Creases was observed on medial anterior sole of right shoe, suggesting increased weight distribution on the area that confirms the flat-footedness on right, present where patient's foot is inverted and plantar flex. No redness was observed on the right foot and ankle, since pain and swelling is absent in chronic ankle sprain conditions. Negative tropic skin changes are also not are observed on right foot and ankle. On palpation, patient is normothermic and normotonic on bilateral lower X. Positive muscle guarding is observed on right ankle towards plantar flexion and inversion. Tightness on right plantar flexors and inverters was observed. No stiffness on right foot and ankle. No ecchymosis or bruising on right foot and ankle was observed. In range of motion, it was observed that there is a slight limitation of motion in patient's right foot. In MMT, it was observed that there is weakness on plantar flexors and everters graded 4/5. Loss of strength in peroneals, which are the major everters, are directly related with chronic ankle instability, since peroneals are important for the quick movements as established in the K and GF guidelines. In special tests, anterior drawer's test is used to rule in anterior talofibular ligament sprain or capsular sprain. Geiger's test was used to rule out high ankle sprain on right. Squeeze test was also used to rule out high ankle sprain on right. In postural assessment, it was observed that in anterior view, there is a positive femoral anteversion on the right. Right patella is more lateral than left. Right tibia is more medially rotated than left. Positive flexible flat foot on right. Positive in towing on the right. On posterior view, right tibia is more medially rotated than left. Positive flexible flat foot on the right was observed. In towing on the right was also observed. In lateral view, flexible flat foot is observed on right. It was observed that most of the right limb's postural landmarks compensated for the flat-footedness present in right. In gait analysis, it was observed that patient is ambulatory, independent without assistive device on level surface for approximately 10 meters with the following gait observed. Slightly increase in eversion on early stance phase of right ankle. Flat foot at initial contact on right. This is also due to compensation from the flat-footedness present on right. In sensory testing, 100% intact sensation as to pain, light touch, and pressure using paper clip, cotton, and PT stump, except deep sensation on proprioception, identified position of the right ankle in up, down, in and out for 7 out of 10 trials.
For the functional assessment, the following findings were found. First is the moderate difficulty in single leg standing on right for less than 45 seconds without swaying. Next is the moderate difficulty in stern negotiation as manifested by holding onto the handrails and apprehensive when leading on right upon descent. Third one is the moderate difficulty in single leg jumping on right for 3 out of 5 trials without assuming 2 leg stance in between reps. Next is the minimum difficulty in bilateral jumping for 8 out of 10 trials with proper forefoot landing, also with minimal sound during the repetitions. Another finding was that there was minimal difficulty in unsupported single leg Q races on right, wherein 8 out of 10 trials without assuming 2 leg stance in between repetitions. Now for the 3-meter multiple hop test, this was a test where it basically utilized a single leg hop with a lateral and diagonal directional changes for 3 meters. Those directional changes were alternatively done, and one was done for the left foot and another for the contralateral foot. The time needed to recover for each foot was recorded and compared. For the unaffected foot, it took the patient 8 seconds, while for the involved foot, it took the patient for 11 seconds. For the agility test, the patient first runs forward 10 meters and runs laterally for 5 meters. Then he runs laterally to the left for 10 meters and again runs laterally to the right for another 5 meters. To complete the course, the patient then backpedals for 10 meters back to the starting point of the course. Studies found that the typical times for athletic adults are between 8.9 to 13.5 seconds. The patient was only able to cover the whole course for 15 seconds, 5 seconds. However, the patient was only able to cover the whole course for 15 seconds. The first outcome measure used for this functional assessment is the ankle joint functional assessment tool. This is composed of 12 questions wherein the subject is instructed to answer each question by choosing the statement which best describes the current situation of the involved ankle, as compared with the contralateral ankle. The statements are graded 0 to 4, wherein a higher grade is equivalent to a greater functional ability. As a summary, a lesser AJ-FAT score shows a lesser functional ability. Despite the tool's ability to effectively distinguish between those with functional ankle instability and normal individuals, the tool does not have sufficient information regarding the minimal clinical important difference, or the MCID. For the next assessment tool, the sport subscale of the foot and ankle ability measure was utilized. This subscale is an 8-item scale which also has a grading system of 0 to 4, and it uses the same concept of having a higher grade which is equivalent to a greater functional ability. Also, it allows the patient to subjectively rate his level of function for usual daily activities and his current level of function in general.
Other inconsistencies in the case are as follows. Functional assessment in stair negotiation revealed difficulty upon activity without aforementioned narration of the patient from the subjective assessment. Changes in the time of the stance and swing phase in the gait assessment were not stated even if there were deviations in the patient's gait. Muscle guarding can also be considered as an inconsistency because it did not state whether the guarding happens in a weight-bearing or a non-weight-bearing activity. The presence of tightness in the plantar flexors and inverters should contribute to a greater loss of motion in dorsiflexion and eversion, but had only minimal decrease in values as seen in the objective assessment.
For additional exams, the PT could use other special tests, such as the Taylor tilt test, in order to determine if other structures are affected. Also, for advanced hopping skills, directional changes for single leg hopping should be beneficial for functional assessment. The patient may also be required to run down the basketball court with and without a basketball. In this test, the time recorded for both trials may be compared to previous records made by the patient prior to injury. Lastly, for the subjective part, it should have been noted by the PT whether the patient executes proper warm-up and cool-down before and after activity.
Based on the KNGF guidelines, these are the most common chronic ankle sprain presentation. Complaints of giving way, history of recurrent sprains, proprioceptive deficits, and it will present with functional disabilities. This table shows the similarities and differences between chronic ankle sprain and its similar conditions. In acute ankle sprain, they both project an instability in the ankle. However, acute ankle sprain has presence of pain, swelling, and ecchymosis over the lateral aspect of the ankle. In sinus tarsus syndrome, they are similar in the presence of feeling of giving way of the ankle, aggravated by weight bearing, and in mechanism of injury, which is inversion. However, they differ since sinus tarsus syndrome possesses pain upon pressure on lateral malleoli. In subtalar joint instability, they are similar due to instability on the area. However, differ in presence of increased values of talar tilt and talocalcaneal displacement, which is measured with standardized stress radiographs. In subluxation of the peroneal tendons, they are similar since both possesses ankle instability and chronic in nature. However, differ due to pain on posterolateral aspect of the ankle, moving tendon on the outside of the ankle, sharp pain upon movement, tenderness behind lateral malleoli, and a higher arc foot.
So, as an athlete, the patient presents with tightness of right ankle plantar flexors and inverters due to extensive basketball trainings and has postural deviation of flat-footedness on the right, leading to gait deviations such as flat foot at initial contact of the right leg and increased aversion upon early stance phase. The tightness of the mentioned muscles contribute to an inverted ankle sprain because the presentation of the foot upon injury is plantar flexion and inversion. Also, studies have shown that flat-footedness can contribute to ankle sprains.
PT diagnosis. Medical diagnosis of grade 2 ankle sprain on right, further defined by difficulty in playing basketball as a small forward for the men's basketball team of his college, secondary to ankle instability and impaired proprioception.
The prognosis for the patient is good. This is because the patient's impairments like the limitation of motion, muscle tightness, muscle weakness, deficit in proprioception, and functional limitations are mostly manageable by physical therapy management. However, patient presents with risk factors that may predispose him to recurrence of ankle sprains. The prognosticating factors identified were as follows. The positive factors include the patient being non-hypertensive, non-diabetic, and non-asthmatic, the patient's age, and the fact that he doesn't smoke cigarettes or drinks alcoholic beverages. These factors would mean that the patient will be able to comply to the treatment with less difficulty. The negative factors include the patient's athletic lifestyle, which would mean that the patient puts an increased amount of stress on his foot even after the injury is treated. The patient's history of ankle sprains will also be a factor. Based on a study by the Hong Kong Sports Institute, it stated that as much as 73% of all athletes had recurrent ankle sprains, and 59% of these athletes had significant disability and residual symptoms, which led to impairment of their athletic performance. As it was said in the objective portion, the patient's flat-footedness can also be a reason for recurrence. Other negative factors found were the patient's report of no usage of ankle support during training and his impaired proprioception, which could lead to further instability of the ankle. The chosen intervention scenario for the patient was restore and adapt. Restore because all of the patient's impairments are manageable with PT interventions, and adapt because patient will need to modify some activities like using taping techniques and ankle support while training to prevent further injury and provide stability to the ankle while treatment is ongoing.
The problem list is as follows. Number 1, ankle instability, LOM of right ankle plantar flexor and inversion, tightness of right plantar flexors and inverters, muscle guarding of right ankle towards plantar flexion and inversion. 2, impaired proprioception of the right ankle with moderate difficulty in stair negotiation and moderate difficulty in single leg standing on right. 3, postural deviation and gait deviation. 4, muscle weakness of right ankle everters and plantar flexors. 5, minimum difficulty in unsupported single leg heel raises. 6, minimum difficulty in bilateral jumping. 7, moderate difficulty in single leg jumping on right. 8, ankle joint functional assessment tool score of 22/48. 9, 3-meter multiple hop test. 10, agility test. 11, foot and ankle ability measure sports subscale score 20 out of 32.
The impairment that needed to be addressed first was instability of the right ankle. Under it is LOM, tightness, and muscle guarding. As stated on the KNGF Clinical Guidelines of Chronic Ankle Sprain, page 19, proprioception should be trained using full range of ankle motion in order to activate mechanoreceptors at all possible joint angles. Next is impaired proprioception of the right ankle, along with moderate difficulty in stair negotiations and moderate difficulty in single leg standing on right. Both functional activities are a result of the impairment, and by treating the proprioception deficit, both functional activities can also be addressed. Postural and gait deviation is third, since the flat-footedness exhibited by the patient is flexible and less difficult to treat compared to a rigid one. Also, the gait deviation is a result of the flat-footedness, which is a postural deviation. Muscle weakness of right ankle everters and plantar flexors are treated fourth and last for the impairments because it still has a functional grade of 4 out of 5, and treated before the functional activities because based on the KNGF Clinical Guidelines of Chronic Ankle Sprain, page 12, peroneal muscle strength is considered important for quick movements. Ankle Joint Functional Assessment Tool measures the general functionality of the ankle, and the score should improve after all functional activities return to normal. 3-meter multiple hop test and agility test are addressed last because both are basketball drills that required all other impairments to be addressed first to be performed normally. Foot and ankle ability measure measures the limit of function based on strenuous activities, which is expected to improve after all impairments and difficult activities have been addressed. Long-term goal, rehabilitative. Patient will be able to return to competitive basketball as a small forward for the men's basketball team of his college without feeling of instability after 6 weeks of PT session.
STG. Patient will demonstrate full ROM of right ankle plantar flexion, dorsiflexion, inversion, and eversion, manifested as reaching a firm end range without pain, after 6 PT session to facilitate improvement in performing basketball drills. Patient will demonstrate proprioception on the right ankle, manifested as 10/10 identified position of the right ankle, such as up, down, in and out, from 7/10 trials after 12 PT session to facilitate improvement in performing basketball drills. Patient will demonstrate no difficulty in stair negotiation, manifested as not holding onto the handrails and no apprehension when leading on right upon descent, from moderate difficulty after 6 PT session. Patient will demonstrate decreased feedback when ambulating from using visual, verbal, and tactile feedback to verbal and tactile feedback after 6 PT session to facilitate normal gait pattern. Patient will demonstrate decreased feedback when patient is in a standing posture from using visual and verbal feedback to verbal feedback after 6 PT session to facilitate proper posture. Patient will demonstrate increased muscle strength of right ankle evertors and plantar flexors from 4/5 to 5/5 after 4 weeks of PT session to facilitate improvement in performing basketball drills. Patient will demonstrate no difficulty in unsupported single-leg heel raises on right, manifested as performing 10 out of 10 trials without assuming two-leg stance in between repetitions from moderate difficulty after 12 PT session. Patient will demonstrate no difficulty in bilateral jumping, manifested as performing 10 out of 10 trials with proper forefoot landing and with minimal sound from minimum difficulty after 6 PT session. Patient will demonstrate decreased difficulty in single leg standing on right from moderate difficulty to minimum difficulty, manifested as standing on right from more than 45 seconds with handheld support and without swaying after 9 PT session. Patient will demonstrate decreased difficulty in single leg jumping on right from moderate difficulty to minimum difficulty, manifested as performing 9 out of 10 trials without assuming two-leg stance in between repetitions after 9 PT session. Patient will report increased ADGFAT score from 22/31/48 after 4 weeks of PT session. Patient will demonstrate symmetric 3-meter multiple hop test between right and left leg from a difference of 3 after 15 PT session. Patient will demonstrate agility t-test within the range of 8.9 to 13.5 seconds from 15 seconds after 15 PT session. Patient will report increased FAAM score from 20 to 29/32 after 4 weeks of PT session.
These are the treatment plan prepared for patients with chronic ankle sprain, based from Kisner, KNGF, and ACSM guidelines. Patient will be seen and treated as outpatient 3 times a week for 6 weeks with the following PT interventions. Taping using low-dye technique with adhesive non-elastic tape on right ankle to address ankle pronation. Despite the use of low-dye for plantar fasciitis, it also provides a proprioception feedback to the ankles. GPS of right ankle plantar flexors and inverters times 15-second hold times 3 reps to increase ROM. Raising of medial longitudinal arc on right ankle while sitting times 10 reps times 3 sets to decrease flat-footedness. Weight distribution on right foot while sitting times 10 reps times 3 sets to facilitate heel strike and gait. PRE using gold TheraBand on right ankle towards plantar flexion, eversion, and inversion times 10 reps times 3 sets to increase muscle strength. Heel raises on right with 3-pound dumbbell times 10 reps times 3 sets to increase strength. It was observed that PREs are done towards all movements despite grade 5/5 of dorsiflexors and invertors. It was done to increase the stability of the ankle. It was also observed that GPS is done first, since any increase in the active or passive range of motion of the ankle should immediately be followed by proprioception training and stability exercises to reinforce the new increase. Resisted forward and backward walking using black TheraBand on right ankle times 10 reps times 3 sets to promote ankle stability. Perturbation exercises on right using block TheraBand to promote stability. Bilateral partial squats on wobble board times 10 reps times 3 sets to improve proprioception. Single leg partial squats on right leg times 10 reps times 3 sets to improve proprioception. Crossover sidestepping using block TheraBand times 10 reps times 3 sets to improve proprioception. Jump and freeze exercises times 10 reps times 3 sets to improve stability. Agility exercises performing karaoke with 10 cones to improve agility. Agility T drills to improve agility. Functional simulation of layups with push-off on right times 10 reps times 3 sets to decrease difficulty in performing layups. As said a while ago, increase in ROM must be followed immediately by proprioception training and stability exercises to reinforce the new increase. On strengthening and balance exercises, it was done to reduce the feeling of giving way episodes and to improve the patient's function.
Home exercise program are as follows. Gastrocnemius stretch on inclined plane times 15 seconds hold times 3 sets to increase ROM. GPS of ankle plantar flexors and inverters times 15 seconds hold times 3 reps to increase ROM. Jump and freeze exercise times 10 reps times 3 sets to improve stability. And heel raises times 3 seconds hold times 10 reps to increase strength. Resistance exercises using towels times 10 reps times 3 sets towards dorsiflexion on right foot to increase strength. Strengthening exercise using towels towards inversion and eversion times 10 reps times 3 sets on right foot to increase strength. Agility T-test drills times 10 reps times 3 sets to improve agility. And simulation of layups with push-off on right times 10 reps times 3 sets to decrease difficulty in performing layups.
Now for the patient education. The first one is to inform the patient about his condition and the course of the PT management, which is mostly about the duration of the treatment, and we may address other concerns by the patient. Next is to educate the patient about proper application of taping techniques and use of ankle support to minimize possibility of injury, while not fully relying on these techniques. It is also important to explain to the patient the importance of warm-up and cool-down prior to and after activity in minimizing injury. Also, the patient must be informed about the benefits and significance of compliance to HEP in improving his condition. Patient must also be educated about the importance of allowing time for recovery on the occasion that injury reoccurs. Patient should be able to rest properly in order to prevent further complications. The patient should also be advised to avoid the mindset of underestimating the injury despite its prevalence among athletes. Most importantly, have the patient to restate HEP and importance of executing it. That concludes our report regarding chronic ankle sprain. Here are our references and the sources used for this report. Thank you for listening.